Namaste, everyone. I am Neha Molla, the co-founder and director of programs at SOCHAI. From the entire team of SOCHAI, I would like to welcome you all to today's webinar titled Bridging the Gap in Action for Wasting. SOCHAI, in short for Social Change Makers and Innovators, is an award-winning young women-led nonprofit organization that aims to improve the overall health, nutrition, and socioeconomic status of people, particularly women, children, and girls, through the approaches of education, innovation, and entrepreneurship. Today, we are talking about child wasting, which is one of the most life-threatening forms of malnutrition. Globally, it is responsible for 1 in 5 deaths of children under the age of 5, making it one of the top threats of their survival. According to the recent data of the Nepal Demographic Health Survey in 2022, 8% of children below the age of 5 years suffer from wasting in Nepal. A severely wasted child is up to 11 times more likely to die than a well-nourished child, but its treatment is possible. To address the issue of child wasting, the Government of Nepal has been implementing the Integrated Management of Acute Malnutrition IMAM program nationwide, and recently in November of 2023, the WHO's guideline on prevention and management of wasting in infants and child under the age of 5 years has been launched. So, we are very excited to bring forward today's webinar on the topic IMAM from global to local. And this webinar is being organized by Action Against Hunger, also known as ACF, NTAG, and SOCHAI, with the support of Eleanor Crook Foundation. With today's discussion, we aim to divulge into the innovations, research trends, and local action and community practices to address acute malnutrition all over the world. For this, we have a diverse cohort of speakers lined up for today who will share their valuable insights on child wasting. This webinar is our effort in creating a learning and sharing platform for all professionals, nutrition enthusiasts, and young people. But before we move on to today's agenda, let's start with a quick ice-breaking activity where we also want to hear from all of you. For this, we have created a Mentimeter poll whose link will be shared in the chat box by our colleague Neha Karki. If you check your chat box, there's a link shared of our Mentimeter poll, and we have a few questions that will now be displayed on the screen. You have to click on the Mentimeter link where you'll get logged in, and then you'll be able to reply to our question. So Neha, can you please share the first question? Yes, I hope everyone can see the question series that will now be displayed on the screen. And you have to click on the mentimeter.com link and then enter the code that's being displayed on the chat box. So you have to log into mentimeter.com. Yes, the link has been shared on the chat box, and then after that, you have to enter the login code that's being displayed. Is it accessible now? Can anyone confirm? Yes, thank you. Now let's move to the first question. Yeah, so the first question is, where are you from? So we want to hear from which organization and where exactly are you logging in for today's webinar? Okay, I can see some responses here. So we have participants from Bhaktapur, KUSMS, Dhulikhel, Dharan, Kathmandu, from HKI Nepal, from WFP Surkhet team, Central Campus of Technology Dharan, SOCHAI, ACF France, ACF headquarters in Nepal, Chitwan, Kathmandu Medical College. Thank you so much for your responses, and we're so happy to have participants from different locations here in Nepal as well as from ACF France today. Now, moving on to the next question, whose link has again been shared at the chat box. What do you think of child wasting? So we already have some responses where moderate acute malnutrition, and it's a global issue, malnutrition, responses like these have popped up. Can you all please respond to this as well so that we can have more of this visible on the screen? Sadness, yes, it's definitely a sad situation. Acute malnutrition, MAM is repeatedly coming up. Yeah, it's a global issue. Low weight for height. Mortality, yes, and also a silent emergency. Poor condition. Yeah, it needs immediate action, and we need to work on it right now. Yeah, very high burden in Nepal. Thank you so much for all these responses. We're very happy to see this active participation. And now let's move on to the next question. Done? Yeah. Oh, thank you so much. Thank you so much for the responses and being so active on our Mentimeter poll. And we can see that you're really excited to move on to the topic and hear from our speakers. And we also had a lineup of your opinions and expectations while we opened up the registration link, and even the questions that were shared on the registration was quite evident that we all have really enthusiastic participants, and I'm sure and very much confident that today's webinar will be a great learning platform for all of us. So talking about today's webinar discussion, we have 5 speakers from across the globe. So we have 2 international speakers joining in from ACF France, and 3 speakers based here in Nepal who work in different sectors, addressing and working directly in the sector of acute malnutrition. We're very happy to have Dr. Benjamin Guedon, Dr. Karine Leroche from ACF France, and Mr. KP Lomsal from UN World Food Program Nepal, Dr. Subhash Sharma from Provincial Hospital Surkhet, and Nawal Kishore Yadav from Asman, Nepal. Thank you so much for joining in, and we now will move on to the individual presentations from all our 5 speakers today. So I would like to request all our participants to take note of the points that they will be sharing. And if you have any questions, we have a Q&A session lined up at the end of all the presentations. So we'll be collecting your questions from the chat box. And my request is please direct the question to the specific speaker so that it will be easier for us to moderate the Q&A session at the end. So now I would like to request and introduce our first speaker for today, Dr. Benjamin Guedon, who is the Nutrition and Health Research Advisor from ACF France. Dr. Guedon is a Nutrition and Health Research Advisor at ACF France, and he specializes in acute malnutrition. With 13 years of experience, he has led global studies, notably in Nepal, unraveling clinical profiles and nutritional needs. His work informs discharge-based practices and policy through cohort studies and data analysis. He's now focusing on home-based nutrition solutions to reduce the dependence of acute malnutrition management services on specifically formulated foods. So I would like to welcome Dr. Benjamin, and today he'll be sharing on the research study, especially on the topic of anthropometry at discharge and risk of relapse in children. So welcome, Dr. Benjamin, and thank you so much for joining us today. Over to you.
Hello, namaste. Thank you for this introduction. I'm going to share my screen. Is it possible for you to authorize me to share the screen?
Yes, Dr. Gedon.
Um, Hmm. It looks like only one participant can share at the same time. So maybe somebody is sharing already.
Dr. Gedon, can you please check now if you can share the screen?
No, for some reason it's not working. Okay, I think it's going to be possible now.
Yes, we can see it.
Oh, here I am. So I'm glad to present today on the important topic of anthropometry at discharge and risk of relapse after treatment of acute malnutrition in children. This presentation mostly draws from a cohort study that we implemented in rural Nepal in 2019. So here is a representation of the caseload of varying profiles of SAM and MAM cases as per the two acknowledged criteria, anthropometric criteria used to define acute malnutrition status. So you have a mid-upper arm circumference on the left and weight for height Z-score deficits on the right. So you can see the size of the populations of children who are identified with a very low MUAC and weight for height Z-score in the red circles, and the size of the populations of children who are identified with a MUAC with a bit less severe deficits and weight for height Z-score with a bit less severe deficits in yellow. And the overlap in between these two populations is in the middle. So this is a global picture that you can find when aggregating hundreds of representative surveys. However, there are contextual variations. And for instance, you should expect an increase in weight for height Z-score only detection during crisis or under high prevalence context. So basically, you will see a larger size of the circles on the right in such context. But that is the global picture that you can draw from aggregating surveys. So in this context, WHO normative guidance is that all SAM cases should be treated and treatment should be performed until recovery is reached, when recovery is defined as observing a change, an improvement from all anthropometric deficits that are present upon admission, according to all criteria. Also, all MAM cases should be managed according to WHO normative guidance, and by default, management include reliance on an improvement of the nutritious food at home and about the health assessment and health follow-up. But it can also include supplementation, although this is not by default. Now, for at least a decade now, there has been a widespread promotion and implementation of a double standard. And in particular, what we have been observing is the use of this promotion and implementation of double standard was mainly due to for the sake of simplification, and it relied mainly on the non-use of weight for height Z-score for the detection, admission, as well as for monitoring treatment response. So only the populations of cases on the left, according to a low MUAC, are considered. You have also in this double standard very frequent use of a higher cutoff for MUAC, usually MUAC below 125 millimeters for treatment eligibility, and then use of RUTF for all eligible children, whether they are SAM cases or MAM cases, and switch to a lower dosage of LUTF when the MUAC of the child gets above 115 millimeters. There are three major potential inconveniences with this approach. The first is, of course, target restriction, as evidence on this figure. The second is loss of therapeutic effectiveness, potential loss of therapeutic effectiveness due to wrong classification, so treatment decision and treatment outcomes. And finally, an issue with cost feasibility of using LUTF for treating MAM children when MUAC cutoffs are extended. Regarding loss of effectiveness, a key question that remains unanswered about this approach is the level of recovery reached when the use of MUAC, when MUAC is used as a standalone anthropometric discharge criterion. For instance, in Nepal, according to the national protocol, current national protocol, recovery criteria are the following. After a minimal length of stay of 6 weeks, it relies on reaching a MUAC above or equal 115 millimeter, together with no edema and a weight gain, observed weight gain, and a good clinical status. So it's only based on attaining a given MUAC cutoff, basically. While for WHO recommendation for discharge, they have always been requesting to ensure the correction of the MUAC and weight for height Z-score deficits present upon admission till reaching a high level of MUAC and a high level of weight for height. So it has been well described that discharging children based only on an attained MUAC cutoff paves the way for stopping treatment too early in vulnerable patients who may still suffer from large weight for height Z-score deficits. Now, the clinical consequences of this remain unclear. Indeed, these children with the remaining deficits, weight for height Z-score deficit, may still be on the right tracks for true recovery after discharge, or they might be at increased risk of deterioration. So in order to further elucidate this, we decided to organize a post-discharge follow-up study. The purpose of the study was to assess the safety of discharging children as cured with remaining weight for height Z-score deficits through post-discharge follow-up of relapse as SAM. The study was an observational study in Parasi district in Nepal on patients discharged as cured in 13 outpatient treatment centers spread throughout the district. Recruitment started from July 2019 and it happened till March 2020 when it was stopped due to COVID-19 related movement restrictions. The follow-up relied on home visits as an effort to minimize loss to follow-up, and it was prolonged till 6 months after discharge. The health outcome of interest in this study was relapse as SAM, defined as the presentation of any SAM case definition criteria in children who were initially discharged as cured and free of SAM. So here are the results. Out of 141 patients discharged as cured from the study centers during the recruitment period, 108 contributed to the analysis. Most patients in our cohort arrived to treatment with a weight for height Z-score below -3, and much less frequently with a MUAC below 115 millimeters. which is in line with the prevalence of these different deficits in the community and in the region. Now, regarding the presence of anthropometric deficits at discharge, here is the figure. As we were expecting, considering the less stringent discharge criteria applied in Nepal, we observed 64% of children were still MAM upon discharge, 49% with a weight for height score below -2, 34% with a MUAC below 125 millimeters. And we were able to have a very complete follow-up of these children with only a few lost to follow-up. So we observed now the main results of this study is about relapse. And we observed a very high incidence of relapse during follow-up. In total, 1/3 of the children in our cohort experienced an event of relapse as SAM. And this mostly occurred in the first 3 months after discharge. When analyzing the association between relapse and discharge characteristics, we found that as a whole, being discharged without reaching WHO recommended criteria exposed the children to a high risk of relapse, with a 3-fold higher risk observed in these children. We then looked at the specific contribution of the different types of anthropometric deficits remaining at discharge through multivariate analysis, adjusted on age, sex, and length of stay. And we could see that weight for height score deficits at discharge were the only ones to be strongly and significantly associated with relapse in univariate as well as in multivariate models. Our results indicate that discharging children before they reach a weight for height score above -2 dramatically increases their risk of relapse, even when they have already reached a MUAC above or equal 125 millimeters. So there are many strengths and limitations in this first study. This was the first study investigating the impact of failure to abide by WHO recommendations for discharge and the respective contribution of remaining MUAC and weight for height deficits at discharge. We did so in using an inclusive definition of relapse as SAM in an unselected cohort of children initially discharged as children. Sorry? 2 minutes? Yeah. This study also adds to the scarce body of evidence coming from South Asia. Of course, these results also come with a range of limitations, starting with a low number of observations. However, since that time, that study was implemented in 2019, results were published in 2021, and since that time, the results have been confirmed by another study published in 2023, a study with post-discharge follow-up in Mali, and also it's getting confirmed with from a meta-analysis of 19 studies with post-discharge follow-up. So yeah, since that time, these results have been confirmed. So that according to the WHO 2023 guidance, which was released fully in October 2023, these include now a more stringent definition of recovery, whereby both a high level of MUAC above or equal 125 millimeter and a high level of weight for height score above or equal -2 should not be reached for a child to be considered as cured from treatment, even under exceptional circumstances. So here is a reminder of the key findings. Our results indicate that discharging children before they reach a weight for height above -2 dramatically increases their risk of relapse, even when they have already reached a MUAC above 125 millimeters. Thereby, they challenge the safety of using MUAC above or equal 125 millimeters as a standalone discharge criterion. There are, of course, recommendations for research Obviously, more follow-up studies are required in other contexts, especially in contexts where NUAC-only protocols are implemented. And further follow-up studies in general are required to set evidence-based discharge criteria. However, we have immediate recommendations for technical advocacy, which are an urgent need to abide by the latest WHO 2023 recommendation on recovery criteria. And considering these renewed WHO guidance, we believe that the promotion and scaling up of protocols omitting the use of weight for height Z-score and relying only on NUAC measurements should be put on hold. So this is the end of my presentation. I would like to remind the audience about the partners and all the team members contributing to the study in Nepal, starting with the ACF research team, which contributed to the study, our academic partners in Nepal, as well as at the international level. Thanks.
Thank you, Dr. Gedon. Firstly, just wanted to check in. Are you feeling fine? Because you had been coughing during PowerPoint. Yeah.
Yeah.
Thank you so much. We really appreciate you being here despite your sickness. And thank you so much for highlighting your very important study and findings of shedding the light on the reliability of MUAC-only protocols that's increasing the risk of relapse in SAM and MAM cases. So thank you so much for your for this deliberation of your research, and also summarizing about the global context, not just limiting this study to Nepal, but in other countries as well, with your experience. So thank you once again, and we really appreciate your time and your presentation being here. Now, I'd also like to request all our participants to note down your questions if you have any for Dr. Benjamin Gedon, specifically on his research that he presented just now. Please mark your questions to Dr. Gedon and share it in the chat box, and our team will be collecting it so that he'll address it at the end of all the presentations from the speakers today. And now, moving on to our second speaker, Dr. Karine Leroche. It gives me great pleasure to introduce Dr. Karine, who is a mental health and psychosocial support research advisor at ACF France. She has developed and implemented the MHPSS and child protection program in various humanitarian contexts in Europe, Asia, and Africa. Her main areas of research focus on topics related to maternal mental health, early childhood development, maternal and child health, and nutrition, as well as mental health and psychosocial support to vulnerable populations in low and middle income countries. Welcome, Dr. Karine, and we're very happy to have you here. So over to you.
Thank you. Namaste and good morning to everyone. I'm so glad to have this opportunity to share with you the findings of the study on social representations of undernourished children and what lead to health-seeking behaviors for those children in Nepal on behalf of our research team. The background of this study was actually referring to some gap and lack of adherence to the treatment that was offered to the children, reducing its potential benefits. This is what we discovered throughout the clinical trial FUSAM project that we implemented in Saptari district between 2014 and 2018. What we actually were wondering was about the traditional beliefs about undernutrition. We knew that it may inhibit relevant health behaviors because that's also what we've seen in other contexts. So what we wanted to do is to explore the social representations of undernutrition in different contexts in Nepal by different social actors and their associations with health-seeking behaviors. This was really the objective of this study. Those questions came out from the clinical trial after community screening and referral of some children. Those children were actually not reach the OTP centers. So we were wondering what were the health-seeking behaviors of the families when they found out that their children was affected by SAM, and how we could improve the referral mechanisms. So we implemented the study in 2 districts, in Saptari district, where ACF already had some activities for the FUSAM trial, and we implemented the other study in Wakot district, where ACF also had some activities. So we use a mixed methods. I'm going to present 3 of the method that we used. The first one was a questionnaire survey with community members. So we included 370 community members for both from both districts. We sample size depending on the VDCs, and we try to have a mix of urban and rural participants. What were the communication opportunities? We had some kind of criteria. So what we did as a procedure for this methodology, we actually showed a picture of some children, and then we asked open-ended question. And we recorded all the reaction, what were the opinion feedback on what were the supposed causes of the child's condition, what would others say about their children, and what would be the health advices the most relevant to provide. We then collected, of course, information on age, gender, caste, district, level of education of the parents, number of children, position in the family, household outcome, to see what were the influencing factors. So for the data analysis, we had to make like 3 categories out of the information collected. The first category was about to bring the child to a healthcare provider. Second one was about giving food or treatment to the child without seeing the healthcare provider, and what were the other strategies. That was the third category. Then we used some kind of software to do like cluster analysis of the narrative data, and then we compare the open-ended answers to the answers from the questionnaires. Okay, so what we found out is when there is some advice by the healthcare providers to go and see the healthcare providers, usually the participant will also have a representations of a sick child. What you see on the left side, it comes from the narrative analysis. So when you see like the child, which is like in big letters, or sad or feel, it means that is the most common answers that were given by the participant, and also what it was related with. For example, they would mention when they see the picture, the child who is sad, feels sorrow, love, worry, surprise, fear, related to God, and pray for this child. So what came out from this, when the child is seen as a sick child, there is in the discourse some oscillation between the biological and societal discourse. So it can be related to poverty and lack of care and food, like for example in Wakot, or it would be related to like going to hospital in order to repair mother's fault. That was mainly reported in Saptari. And also that medical complication was associated to family issues. So it's more about the child environment and the caring environment than related to any other external factors. And what others would say about this was that it was probably a problematic family organization. That's how they perceived others towards their child sickness. The other category that came out was advising to treatment. I can't see my slide, sorry. And then there was this representation of a poor child. So when others would see sick child, some would see the poor child because they focus on how the body would look like. And then this was highly related to other stereotypes about poor and useless family. Basically, if the child is sick, it means the family is poor and useless, can't get any solution. So there would be from outside, they would see the mother as careless. Other causes could be like lack of care, which is very anchored in the medical discourse. And the other answers would be like they are poor, so they do not take care of their children. The last category was advising to go for traditional healing representations of a strange child. And they focus then on the emotion felt when looking at the picture. It's not anymore about the sickness or how the child looks like. It's about the emotion felt while looking at the picture. And then any other causes are good to think about this. That could be from lack of food and love to black magic, like in Wakot it was reported, or divine punishment of the mother who should bring the child to hospital. And finally, the perception would be a careless family causing mother's fault. So in the second part of this mixed method, we interviewed health staff. So we interviewed 5 people in Saptari and 4 in Wakot. So the methodology was a bit like the same, bit similar. We use the same picture and we show of the same child. We show it to the interviewees and we ask for their feedback. Then we ask questions focusing on representation of malnutrition and also questions which were related to their activity and their role in fighting against malnutrition. So the interviews lasted about 66 minutes, audio recorded, translated in the local language, and then transcribed in local language and translated in English. So what we found out is like the perceived cause of malnutrition and related issues by the health staff are very specific. When they are asked about
recording stopped,
the lack of vital care comes from, then they would say, okay, if there is no knowledge in the family and this child is sick, it means the mother is just negligent. She's not taking care of her child and the child will not recover. If they think there is some knowledge in the family, then the question would be, does the child recover once the mother is informed? Like, shall we educate the mother, inform the mother so she can take care of her child? And then again, they think there are 2 options. No, she can't be a knowledge, so she will be negligent and the child will not recover. And yes, we can inform the mother, we can educate the mother, support, build her capacity, and then the child will recover and exit from the vicious cycle of poverty. The perceived causes of how health worker and female community health volunteer conceive their work is again 2 ways. They think they can make changes by educating the mothers, and then parents would be responsible for care of their children. Comes again 2 options. Either they are poor, they consider that those people are poor, so they can be bad poor, and in that case they will not be cooperative, so they can't participate really to the care of the children, and again they will be negligent. Or they are the
recording
good
in
poor,
progress,
who will be knowledgeable and might be able to make change in the child's life. Or on the other way, they think that the child is just innocent and malnourished. So it's just about coming to bad issues for the child and then stays in the cycle of poverty, or the child might recover and parents will be educated and again get out of the circle of poverty. The last part of the mixed method was on with focus group discussion with mothers of some children. So we conducted 5 focus group discussions, 2 in Saptari, 3 in Nouakchott. There were about 5 to 7 women in each group. Their children were between 6 to 23 years old. And they were selected among the mothers in the community and the one, of course, coming to the OTP. They were like homogeneous related to their caste, and they attended the same OTP centers. So the method was about trying to get them as comfortable as possible and asking questions about them as a women. What change was introduced in their life as when they became mothers, were a mother, how they could list the symptoms when they were worried about their child health as a whole. They were asked then to offer to discuss around this, the picture of children. And then they were asked to describe what was happening when they found out that their children had SAM, and then with pictures illustrating, the key moments. And then we offer them the opportunity to make the scenario and discuss about this and see whose child has been diagnosed with SAM, receive different advices from family members, from traditional healer to advice to go to the hospital. So there was really a long process to make sure they would be comfortable and they could talk freely about the condition in which they got to know that their child had SAM, and what was the decision-making process that make them bring or not bring their children to the health centers for healthcare. So this is how it goes. Malnutrition from caregivers' point of view is first a weakness and thinness, and it leads to disease. It's a disease, or it's not a disease. And then depending on what they think at this level, there would be different options. As you can see, it shows that if it's a disease, then they search for medical support, and it's linked to what I described before. Or they've considered that it's not a disease, that there are external causes, the other determinant, and then they would think that it's from birth, so they can't do anything, there is no solution, and the child will die. Other thing, it's related to lack of food, and then how to recover from that. So is it to search for medical support or to provide better food and care to the children? And then, as you can see, it's related. Then if no recovery or doesn't eat, then it means it's a disease. Or if RUTF is not provided, then again, the mothers are perceived helpless and there is no recovery, and it leads again to disease and death. Malnutrition explained by caregivers in Nouakchott is a bit different. They see malnutrition as any other disease. It's caused by weak immunity because the child cannot eat. It's also related to bad karma and other aspects of the children's life, of the mother's life, of the family organization, and also related to the social environment. For those caregivers, there are 2 ways out. It's the solution on how to recover and the long-term consequences. In this district, the mothers are more educated and receive more information on health in general. So they have the biological, medical understanding of malnutrition more than in Saptari district. So recommendations from this study, we had many, many findings that, of course, I don't have time to present you today. But the main recommendations that we had was that we should not focus solely on caregivers, on what they know or don't know about malnutrition, because they know many other things around malnutrition. They have other solution options. They can be informed and knowledgeable. However, health promotion in is very contextual and should take into account those other forms of knowledge, not only the medical or biological knowledge, because then it's relevant for health-seeking behaviors in some contexts and it won't be relevant in other contexts. Like if you talk about the health aspect of malnutrition in mothers in Saptari district, this might not make sense as much as in Nuwakot district. Also, promoting medical knowledge in communities may not always have positive outcomes. So it does not erase other forms of knowledge like traditional beliefs, but it may even support stereotypical discourse about the careless family. So the more you give some kind of information on the medical aspect, the less you take into consideration other aspects of the families, of the culture, of the conditions of the mothers and the women and other things. So what we recommend is not to bring one way of providing information over another one that would be considered as less important. And lastly, it's very, very necessary, and we could see it throughout the different methods that we use, that acting on the mother, the child, but also on healthcare personnel and more broadly on society's attitudes towards malnutrition is crucial. If we just give information to the mother, or if we do not build the capacity enough of the healthcare personnel, we won't reach the objective, and the efficiency might be as high as it should be. Thank you very much for your kind attention.
Thank you, Dr. Karin, for your elaborate research and findings based here in Saptari and Nuwakot districts. It was really interesting to see the diverse insights that came from socio-environmental factors and regarding the health promotion and health service availability activities and the health-seeking behavior of mothers and families here in Nepal. I can see there are some questions directed at you that we have collected, and we'll get back to you at the end after all the presentations are done. Thank you so much, Dr. Karin. Now, again, reminding all our participants to drop your questions for Dr. Karin and her presentation if there's any on the chat box right now, which our team will collect and will be addressed in the Q&A session at the end. Now, I'd like to move on to our third speaker for today, Mr. KP Lomsal. Good afternoon and namaste, KP sir. So KP Lomsal is the Program Policy Officer at World Food Program Nepal. He has a background in nutrition and dietetics and in nutrition epidemiology, with an experience of more than 10 years in the field of food safety, nutrition, dietetics, and consumer rights protection. He has also published over 1,000 articles and papers and is a regular columnist and editor of various prestigious newspapers and scientific journals. It gives me great pleasure to welcome KP sir to our webinar today, and we're very excited to hear from you. Thank you for your time, sir, and over to you.
Thank you, Nehaji. Good afternoon. I think good morning for Dr. Benjamin and Karin. Am I audible?
Yes, sir.
Yes, thank you. Dr. Benjamin and Karin just highlighted the evidence from Nepal as well as a few global evidences as well. I would like to focus on how we can translate those evidence in the action in the context of Nepal, focusing on the few actionable localized solution to strengthen the wasting management program in Nepalese context. Allow me to start from the trend analysis for of this wasting prevalence in this country. We can see we are progressing well in terms of the reduction of stunting and underweight, but the prevalence of wasting is almost stagnant from decades. So what are the factors behind this? The answer is not straightforward. We should detail deep dive to find out the determinant or the factor behind the wasting prevalence in Nepalese context. If we disaggregate the national data in provinces, we can see that the wasting prevalence is quite high in Tarai area, where we consider as a food hub or the fertile land, and the food availability is not the issue in those areas. So identification of the wasting hotspot is crucial for the better programming in the situation of resource constraint. If we further deep dive with the national data from the national prevalence or from the provincial estimation, there is lack of localized evidence and localized data to guide focus intervention at local level, at district level. The national estimate or the provincial estimate can provide the quite guidance, but to design the targeted program, to design the focus intervention, we should have the localized evidence and localized data. As we know that Nepal is adapting the federal context, and we have 753 local government, where most of the resource from the fiscal transfer from federal government and provincial government, there is a resource at local level, but most of the national survey and the data we have right now is up to provincial level. So identification of the wasting hotspot is crucial for the better targeting, for the focus intervention, as well as to ensure the best value for money that we have been investing in wasting management program. Let's take one example from Bagmati province. Bagmati province, if we generalize the context from the recent demographic and health survey data, the provincial average prevalence for wasting is 4.5%. But there are some pocket area in some communities, in some local government, in some ward or in cluster, where the global acute malnutrition rate, the prevalence of wasting is much higher than the national average. So identification of wasting hotspot and the localized evidence is very crucial to better program and to ensure the best value of the investment, either from the government side or from the other actor. So as we know that the Government of Nepal, with the support of the development partner, we have been implementing integrated management of acute malnutrition program from long time, starting from the community-based approach to the integrated approach. So, but the compliance rate of the Imam program, National Imam program, is not satisfactory as of now. As of today, the National Imam program is scaled up to all 77 district and all 753 local level. But if we compare it with the service utilization rate or the coverage and compliance of those from this program, is still low. So what are the barriers that contribute to reduce the compliance and coverage or service utilization? I would like to categorize this the barrier analysis in two parts. One is the service side barrier, and another is the demand side barrier. So from the supply side barrier, I reviewed them different journal article and the reviews from different experts during the preparation of this presentation, and I found these are the most common supply side barrier which are contributing to for the low level of program compliance in Nepalese context. And from the demand side as well, there are numbers of barriers or the enabler within the household or within the community, but these are the major one, and it's like a low-hanging fruits for us as a program implementer, which we can mitigate easily with very simple and low cost or even the no cost intervention. And I would like to echo with the findings of Karen about the perception of the people, especially the community, about the wasting, how they perceive wasting. Most of the family don't recognize the sign of wasting among their children, or nor do they know about the associated risks of mortality or morbidity. This type of perception at community, and the workload of the mother and time availability to visit health facility to receive the wasting management service, or some types of gender stereotypes and the family support. These are the major barrier from demand side. Of course, there are other barriers as well, sir, but these are the major barrier I found from different research paper focusing in Nepalese context. In supply side, the top one highlighted from most of the paper is access to health service, especially in the mountain region and hilly region. But in addition to this, it is the perception from the service provider, health worker, actually for the management of severe acute malnutrition, the procedure is quite complex in terms of recording reporting. As per the national guideline and the national protocol, the health worker should start from the integrated management of acute, the IMNCI protocol, integrated management of childhood illness protocol. So they should register the detail of children over there in IMNCI register. And then if the child is severe acute malnutrition, they should start the same recording, almost same recording process, following the same the general danger sign to fever, diarrhea, and other protocol, again recording to the IMAM register. So the perception of health worker is it increase the workload of health worker. Why not to simplify the recording reporting tool and the treatment protocol, so that they can easily manage during the high case load as well. So this is simple, tricky things, and it is low-hanging fruits, like it's like a single bullet solution for the recording reporting part, so that it will minimize the workload of health worker, and they can provide more counseling instead of recording the same things in two register. Why not to integrate the severe acute malnutrition treatment protocol in IMNCI protocol, so that they can register in the same recording tool. So this is one of the perception, or let's say this is increasing the workload of health worker. This is the perception from health worker. From the supply side, the supply of the commodities is another barrier, but in the Nepalese context, the supply of therapeutic food and MUSC and other nutrition commodities is not a main barrier from supply side. So of course, sometimes the supply chain gap is we are encountering with the supply chain gap, especially for the RUTF and other commodities. But if we compare this barrier, this supply side barrier, with other country with the similar setting with Nepal, this is not a main supply side barrier. So another major barrier is the quality of service. Especially I would like to highlight here is the counseling, and I agree with the findings of Karen. Just providing the information about the health benefit, just providing one-way counseling to the mother, to the community, or to the household may not enough to change the social and behavior, and it may not be enough to change the social norms as well. So this is another supply side barrier highlighted in most of the research article and reviews in Nepalese context. And we do not have any specific intervention for management of moderate acute malnutrition. During the Menti quiz today, before starting this technical session, I saw most of the response was ma'am. When we ask about wasting, most of the people perceive as ma'am or the sam. So if we treat ma'am on time, it is not necessary to provide the supplementary food or any specialized nutritious food in blanket approach, but utilizing the local solution, if we can prevent wasting or prevent the case at MAM stage, the caseload at health facility to treat severe acute malnutrition or severe acute malnutrition with complication will automatically reduce. So intervention, localized solution and intervention for prevention and treatment of moderate acute malnutrition is also another urgent need in our context. And the commitment of ownership of the different types of government, especially at the provincial level and at local level. Some provinces and some local level, they have been implementing some innovative idea and their localized solution to reduce the prevalence of wasting, to improve overall nutritional status, but it is not across the country. So commitment and ownership of different types of government is another barrier or another area we should consider. And for those, I think motivation of health worker and simplifying their day-to-day work is crucial to motivate the service provider for quality services, as well as the putting the value and triggering the family member and community member, as well as the community influencer to change the social and behavioral norms of the family member or community about the wasting is crucial. For that, of course, we have different social and behavior change communication activities or program, but that might not be enough to Can you share my, can you see my screen?
Yes, sir.
No, sorry. So these are the supply side barrier as well as the demand side barrier related to wasting management program in Nepal. I would like to highlight few potential localized solution. So for that, I would start from the prevention part. Prevention should be first priority always. For the prevention of all form of malnutrition, promotion of locally available nutrient-dense food, and the formulation of local recipe for the supplementary food as well as the therapeutic food is important. I would like to highlight here one innovative approach. The Government of Nepal, especially Department of Food Technology and Quality Control, led to develop one complementary feeding recipe book utilizing the locally available nutrient-dense food. We can find almost 21 recipe over there to prevent all form of malnutrition, and 3 recipes focusing on the wasting part for the mom children, how we can prepare the high protein food and high calorie dense food at household level. It is not recommended for severe acute malnutrition, because for the severe acute malnutrition we have the clear WHO guideline as well as national protocol to use therapeutic food. But for the moderate acute malnutrition, we can use the locally available nutrient dense food and local recipes to prevent and treat moderate wasting. if we promote locally available food, just highlighting the importance of those foods, just promoting the nutritive value of those food, and just highlighting the health benefit, that would not be enough to change the food habit or to trigger the family member or community to adopt those recipes or those food. We should provide the solution as well, utilizing those local food. So this complementary feeding recipe book would be one of the tool to promote locally available nutrient dense food, how the mother or family member can prepare the nutritious recipe for their children in their own kitchen to prevent the children from all form of malnutrition. We have 21 recipe for that, and 3 recipe dedicated to mom children. And this recipe book is not only text. We can find the sketch and picture as well, and easy to use for the mother. We can find the flow chart, how to prepare the highly nutritious food, what are the raw material required to prepare those food on that way. So they can prepare nutritious food in their own kitchen, and they can feed their children with no any additional cost. And I would like to highlight here the SPC approach that we have been implementing in Nepalese context, and what we should change, and how we can make adjustment to ensure the effectiveness of social and behavior change intervention. Of course, we have been implementing different SPC activities, but printing flip chart and IC material and broadcasting the radio PSA and other messages from radio and television, that are, of course, that are tool for the SPC, but not enough to change the social and deep-rooted social norms and behaviors. So for that, we should have the clear understanding of what are the barrier and what are the enabler for the recommended behavior. And we should identify what are the behavior insights and how we can prioritize those behavior insights to design and implement social behavior change intervention. So social and behavior change intervention is beyond the printing flip chart and delivering the flip chart and IC material to health facility to the community. So behavior insight is the crucial things, and it is the key to design any SBC related intervention that is lacking in our context. And I agree with the findings from Karin. If we just provide the health benefit of any product or any service, that might not enough to change the social norms and behavior and the perception of the people and the community. So we should have the clear understanding about the barrier and enabler and the clear understandings of the behavioral insights, so that we can prioritize those ideal behavior and implement the SBC approach from the small doable action, not the ideal one, from the small doable action and the practical approach. So
excuse me, sir. Sorry to interrupt, but just to remind you that your allocated time slot has been exceeded. Also, for some reason, your slide has not been shifted. So we're still on the previous slide. So I request you to wrap up, if possible, within a minute.
My slide is not moving?
No, sir, it was stuck on the previous one. So I request you to conclude your remaining part.
So sorry for that. Actually, I just want to highlight about the screening part of the IMAM program at community level and at the health facility level. I think it is the crucial one, and the important to ensure the program coverage as well. And we see the findings from the Benjamin Muakwanli approach are the Wait-for-Haji score approach, which is based on how we can ensure the the detection of more wasting children from the community. I just like to highlight a few mixed opportunity that we have right now is the Early Childhood Development Center integration with the IMNCI program and the immunization program and the screening in other platform that we have in the community and utilization of the already existing program and services we have right now. So in conclusion, we should translate global evidences to the local solution utilizing our own local context, and prevention should be first and treatment should be non-negotiable to reduce the wasting prevalence in this country. Identification of wasting hotspot and the implementation of targeted approach is important to ensure the cost benefit as well as the effectiveness of those programs, and effective social and behavior change intervention and community sensitization, timely screening, referral and management of wasting cases, and the last but not least, linkage with the performance of local government, because they are the ultimate decision makers. So linkage of the wasting prevalence or the performance of IMAM program to the overall performance and fiscal transfer to the local government is important part. And of course, integration in all possible platform and the program is crucial to ensure the effectiveness of the program as well as to ensure the best value for money that we have been investing for National Imam program. Thank you. I would like to stop here, and sorry for the technical error to move the slide.
Thank you, sir. Thank you very much for highlighting the need and also sharing some examples of the localized solutions for management of acute malnutrition. We really appreciate your in-depth analysis of different research studies for the hotspot targeting for child wasting case identification, as well as highlighting on the barriers on service side leading to low compliance on the programs. Before we move on to our next speaker, I'm again requesting our participants to share your questions for KP Lomsal, sir, if you have any. And also, I'd like to request KP, sir, if possible, during the Q&A session, can you please just show us the booklet comprising of the nutrient-dense food groups as well as the locally available recipes, where we'll direct the questions to you, and we can also have a glimpse of the localized solution that you mentioned. Now moving on to our fourth speaker for today, Dr. Subhash Sharma. Dr. Subhash Sharma is a consultant pediatrician and head of department at the Provincial Hospital, Surkhet, since the last 2.5 years. He has been working in the government sector for the past 8 years, and he has a diverse experience of working in community level in Kalikot, Baake, and Surkhet. He's also a national trainer for the CBI MNCI, FBI MNCI, IMAM, and ITC trainings, and he's also been involved in the CMAM, IMAM trainings, as well as the establishment and operation of OTC center at various places in Kalikot, where the treatment of SAM cases has been very effective. Thank you so much for joining us, Dr. Subhash, and we are very excited and honored to hear from you on the hospital-based management of children with severe acute malnutrition. Thank you, and over to you.
Thank you, ma'am. Am I audible?
Yes, sir.
Okay, thank you, and good afternoon, everyone. So today, basically, I will be talking about hospital-based management of children with severe acute malnutrition. So this is the hospital where I work. The first is the day light view, and this is the night view. So this picture shows the places of management of malnourished children at our hospital. So on your screen, the upper left photo shows the PICU, where if the SAM cases are very critical, we admit them. The lower left shows the emergency, ward where some cases are usually admitted if they have any medical complications. Then upper right is our pediatric ward. So mostly our ITC is here. So we admit the some case with medical complication here. And lower right is the OPD, where the cases come for consultation. Some of the cases are referred from the OTC centers, and some come with medical complaints. So when we screen them, we find out there are some cases, and we, if they have medical complications, we admit them to PICU. Usually, the cases visiting OPDs are admitted at the ITC, at the pediatric ward. And when the cases are stabilized, in the middle, there is a photo of NRC, which is also located within the hospital premises. So we usually put the patients in this NRC. And some of the cases, even in the stabilization phase, they are admitted at the ITC at the pediatric ward. So before starting, I would want to highlight this, that severe acute malnutrition children die because of mismanagement, and it is unknowingly rather than no management. So the health workers try to manage the case thinking that this is normal procedures and normal treatments as of healthy child will be effective towards some patients. But the treatment done for the normal children, it may be very dangerous and sometimes life-threatening to the same patients. So in our hospital setting, basically, I do not want to focus on more on this because most of us know. Only I want to highlight on few of the important topics. So if any of a SAM case come at first, sometimes we do not know it is a SAM case because they come with medical any complaint and they have come for medical advice seeking. So at first we do anthropometry. We look at height, weight, mid-upper arm circumference. We take out Z-score and sometimes edema. So, and we also do relevant medical examinations depending upon the problems they have come to our center. So filling the criteria, if they fall under the SAM category and have any medical complications, we fill the critical care pathway chart. So I will talk about this critical care pathway chart in my next slide. So we find out if there are any medical complications and we identify and we manage them. So most of the common medical complications with the severe acute malnourished children face are, they may have hypoglycemia, hypothermia, severe dehydration, high fever, severe anemia, intractable vomiting. The child may be not alert, and usually child has infection. So after identification of medical complications and management, so we decide for admission. So depending upon the condition, if some case, sometimes they are very ill. So if they are very ill, and if they need close monitoring, such as severe dehydration, need every 10 minutes of monitoring, or if a child is in septic shock, or if vitals are unstable, so we admit them at the pediatric ICU, which I showed the picture. So if they have got SAM with medical complications, but their vitals are stable, and so we admit them to the pediatric ward where our ITC runs. So ITC stands for Inpatient Therapeutic Center. Next, ma'am. So I was talking about this critical care pathway. So this is usually field. So if we have to admit the patient at our ward with medical complications, so we fill this chart. So the advantage of this critical care pathway, this is a chart devised by WHO, so and incorporated with different countries depending upon them. And so this is the chart you followed at Nepal right now. So we write the name, So date of birth, age, date of admission time, everything. So initial management. So so how do we categorize them? So what are the categories needed to classify them? Severe malnourished. So we write the temperature, blood glucose level we write. So and also the amount of blood glucose to be given if their glucose level is less than 54. So about the hemoglobin level to find if they are severely anemic or no. If any eye signs are there, so we start feeding for them. So amount of F75 needed for them. So if they have diarrhea and if they are dehydrated, we also start with Resomol. So we also find out signs of shock. So there are many things. So if the child is lethargic, so the amount of IV fluid to be given. So regarding diarrhea and monitoring every 10 minutes to 2 hours, then every 1 hour. So sometimes health workers feel that this is a burden. So they are already overworked with very limited staffs in a government hospital. So adding new program with this new chart, so health workers sometimes they feel it is a burden. But we counsel them that feeling this child decreases their work on management. So everything monitoring and every clue regarding the management of child is there, and even there is place for antibiotics. So what are the route? So how do we give? So if we feel this critical care pathway chart, definitely it will help us to manage the severely malnourished child in a proper way and very effectively. Next, ma'am. So this table is also devised by WHO. So I do not want to talk much on this. Most of us know. Only I want to highlight few things. So management of a SAM case who has medical complications. So basically it is on 2 phases. So stabilization phase and rehabilitation phase. So stabilization phase usually occurs in the first week usually. So most of the cases, so I have talked about the complications of SAM. If the child is very critical in our scenario, mostly the first 1 or 2 days will be at the ICU because the sisters can more frequently monitor them, so look after the complications and treat them. So even in stabilization phase, some of the cases direct go to the ITC. So initially looking at the critical care pathway chart, it guides us whether the child is hypoglycemic. So we prevent and we treat, and even if there is hypothermia, we prevent and treat. So about the dehydration status and about electrolytes, everything we start from stabilization phase. So after about a week, when a child is stabilized, so for regain of weight and to rehabilitate the child, we start. So electrolyte starts from stabilization till rehabilitation. So treating for 1 week, usually we treat for infections. So depending on the severity and about the nature of infections, antibiotics can vary from IV to oral. So about micronutrition supplement, after the first week during the rehabilitation, we supply with iron. So about the cautious feeding in the stabilization phase to prevent refeeding syndrome and other complications. So catch-up growth usually, weight gain and catch-up growth occurs in the rehabilitation phase, and sensory stimulation is very important for the mental development of the child and during the rehabilitation phase, so to prepare for follow-up. So we follow this act. Next, ma'am. So some of the photos, this is the photo from our hospital. So the left photo, this is the photo of training to the staffs of the pediatric ward and in charge and doctors regarding the ITC, inpatient therapeutic center training, so that they can be acquainted with the latest guidelines, latest measures, and how to develop a feeling that some patients need to be treated in a different way than compared to normal child. So the second picture shows our director is seen in the middle. So he is addressing the participants. So this shows that our director is also very interested in giving feedbacks and assessing and helping us to treat some patients, whether it be at ward, and also to support the SAM patients at the PICU. Next, ma'am. So talking about the strengths of our hospital, so we have highly dedicated staffs. So these staffs includes pediatrician, medical officers, sisters, and supporting staffs. We also have adequate infrastructure. I have shown the picture at my first slide. So we have space at the emergency, at our ward, and even at the ICU. And another strength is the interlink between ward, where our ITC runs, ICU, and a nutrition rehabilitation center. So when any child is kept at a nutrition rehabilitation center, if the child falls sick and immediately needs care, sometimes if the child sometimes aspirates, sometimes anything can happen. So they might acquire reinfection. So they are again transferred back to ITC. And if they sometimes, rarely, they may aspirate to small children, so they might land up in ICU. So there's a great interlink between ITC, ICU, and NRC. So this helps in increasing the outcome and treating the SAM patients. Next, ma'am. So the achievements of our hospital is that we have been able to treat some patients with complications from most of the districts of Karnali and few districts from Sudur Paschim province. So we are the referral centers. So in the provincial level, so anything will be with SAM or mostly these patients come with medical complication. So when we treat these children are treated with medical complications, and we treat for SAM simultaneously. And we have been able to diagnose many Kala-Azar visceral dysgenesis patients who are usually malnourished. So they may not be SAM, some are also SAM. They fall under MAM. So in our province, especially from this Kalikot or SAM belt, so there are many Kala-Azar patients. So despite of not being in the medical guideline of ITC of our country, we do K39 test, and most of the cases of Kala-Azar are diagnosed. And when we anthropometrically test these children, so they either fall in MAM or in SAM. Next, ma'am. So these are some of the activities that are conducted at the Nutrition Rehabilitation Center. I've shown the picture in my second slide. So the upper left picture shows the mothers and their children feeding in our NRC center. So these are during the rehabilitation phase. So emotional bonding is present. So as well as the children's, it is seen that the children's feed well when they see other children's feeding. So the upper right picture shows the same mothers. They are walking. This is the kitchen garden, which is in the NRC. So mothers are using their leisure time in walking the kitchen garden, so they can produce bit of green leafy, let it be coriander, spinach, and all. So they help in that. The first third picture shows various monitoring from EDPs, UNICEF, and other UN, WFP. And the fourth picture, which is the picture where our immunization center is also at the NRC. So we get to screen few of the cases at the NRC to find out new SAM cases. Next, ma'am. So some of the transformation pictures I want to highlight. So this was a case of 17-month male. So admission weight was 4.5 kg. So discharge weight, and the discharge picture is at the third. So weight was 6.8 kg and length of stay was 87 days. And when we see here, The first picture shows the mother, and even the mother is nourished during her stay in the hospital and at the NRC. Next, ma'am. So this is also a recent picture of a 3-year male. So the admission weight was 4.5 kg, discharge weight was 6 kg, and length of stay was 42 days. So the first picture is the case was admitted at PICU. The child was severely hypothermic with temperature of 92 and blood glucose was 28, and even finding vein was very difficult. So initially NG feeding was done. So the second picture is the stabilization phase after 3 to 4 days. And the third picture shows the pediatrician taking round at NRC right now of the same child who was examined before discharge. And one success story, this is a case of severe acute malnourished with medical complication. The child had subaortic ventricular septal defect. So the child was admitted at our center with a weight of 4.5 kg. Weight was, we consulted with the cardiologist in coordination with Gangalal. So after a weight gain needed for the surgery, the child was transferred to Kathmandu. The patient's parents were very poor, so we coordinate with the local NGO to for them to travel to Kathmandu. And after being operated, the child was again brought back to our NRC. So when the child had gained adequate weight, the child was from Kalikot. The child has gone to our respective place. And recently, this child has visited our hospital about 1 month back, and right now the child is of 12 kg. So this is a success case which shows that only medical and stabilization and rehabilitation phase is not enough. So if there are medical complications sometimes which needs operation, they should be done so that they can gain weight adequately. So our institute, we also have witnessed the important weakness are insufficient staff. So we have very insufficient staff. So we have ward of 26 bed with 4 cabins. So we do not have ITC dedicated staffs. So that's why sometimes providing services to some patients following all the protocol is sometimes difficult. So sometimes there's poor compliance of patients during rehabilitation phase. So the mothers, they have so much household chores, so they husband their families. They do not give them plenty of time to stay at the during rehabilitation phase. So they are mentally tortured to return back to home so that they can continue with the household chores. So when they return, so most of the cases become defaulters. So there's poor compliance. And another is due to insufficient resource to manage critically ill SAM patients. So some patients, they are admitted at ITC, but when they need to be admitted at the ICU, so there's only a need of manpower, money, resources. So this is not provided by government. So we need to either request the hospital or to request some NGOs to support them. So that is also a challenge, let's say. Next, ma'am.
Sorry to interrupt, Dr. Subhash. We're running out of time, so I'd like to request you to move
So the
toward.
new innovative measures we have applied is to admit of sick critical cases at ICU for stabilization phase, because our staffs at ward are very less, so they need to take care of other children. So if the child is critical, needs a close observation, we admit them at the ICU. And we conduct regular EPI vaccine at NRC, I have shown, so that we can screen other impending SAM cases. And there is regular pediatrician doctors down at NRC, so we can find if there is any complications related to recovery syndrome at the rehabilitation phase. Next, ma'am. So the recommendation is to increase the number of staffs through ONM survey for quality service. So with this many staffs, it's very difficult to give quality service, and to have motivating schemes in order to retain skilled manpower at periphery hospital. So in periphery, so skilled manpower hardly they are retained. So if we put all the manpowers even from the capital to the periphery in the same basket, obviously the skilled manpower will return to the central. So we will have very less, maybe doctors, sisters at working at the periphery. So there should be some motivating schemes from the government side. And we recommend to classify the ITC into various types depending upon the severity of complication. So we cannot make ITC guideline on the blanket therapy, because our ITC will be running in the 77 districts. So the medical complication handled at the district level, they may be slightly less severe compared to medical complications that are referred to provincial level hospital. So I think the ITC guidelines should be revised in this form. Thank you.
Thank you very much, Dr. Subhash. Even though there was very limited time, thank you for running us through the hospital-based management protocol for acute malnutrition, as well as sharing some best practices and good examples of the treatment process. We really appreciate it. And we can see that we have some questions directed at you, which we'll put forward to you at the end of the presentation from our next speaker. Now, finally, we have our final speaker for today, Mr. Nawal Kishore Yadav. Nawal Kishore Yadav is the Executive Director of ASMAN Nepal, and he has been working here in our country with an experience of over 2 decades with relevant government, non-government, and international agencies. He is a strong advocate for children, youth, and women from marginalized communities, especially Dalits, Musahar, Janajatis, Muslims, and his prime focus has been to ensure that they all are well nourished and are supported enough to go to the school in an inclusive, child-friendly, and safe environment. Thank you very much for joining us, Nawal sir. And he will be sharing about the community perspective in integrated management of acute malnutrition, sharing about the best case practices of the North Camp. Thank you, sir, and over to you. Also requesting you, because we have limited time with us, please stick to the time if possible, sir. Thank you.
धन्यवाद. Slide तपाईले शेयर गर्नुहुन्छ? Slide sharing from your side or our side?
Yeah, we will be doing that.
Okay, okay.
Already
so,
visible.
I'm just introduce myself. You already introduced about me, but I'm a little bit different. I'm not health like a public health personnel. I'm quite different, like a practitioner. What our expert have the knowledge, and those knowledge how to organize in community levels. So maybe my presentation quite different, and maybe different feeling to all of you. I try to sharing my based on my experience. So please move. Yeah, okay. So first slide, I try to my impression about the IMAM program or overall the nutrition. So now we have seen like a government has more investment in the IMAM or nutrition program in the to the center level to the grass level. All of you know, and very significant percentage reduction in malnutrition. And same like previously, all of you know CMAM. Now we have with IMAM. So IMAM is a more integrated intervention in for the nutrition program. So it is quite impressive. And same like capacity building in the health workers, like central level to the grassroots levels, quite good knowledge and trained human resource in case of the nutrition program. And same the good thing is now government have very much commitment to addressing the malnutrition in the various level, either policy and program and partnership with the governments and development partners on a sustainable manner. So this is also a good thing for our country, our community levels. And also community engagement now a strong network in our community levels like MCS, MSN program also give the good picture and the very grassroots levels. MSNP little bit more focus on the grassroots levels like community and world levels. So it gives them a very strong network in the community levels. So through that networks, we can deliver our message, our program in the targeted groups. And same like our integration with the executive service here. Like IMM program, more integrated, like now as a present, then healthcare service, such as maternal and child health program. And this is also maximum efficiency and reach to the broader population. So it is these are the very impressive things. And same like capacity building in the partnership and innovation in the grassroots levels, NGOs, INGOs. Please, next slide. And some quite different, like what their gaps already in my, we try to find out the gaps based on our experience, like Asman Nepal, working in nutrition section, continuous since 25 years. So we have a lot of intervention in the Madhya province and even in the Sudar Pasim. But some quite also good things, but still we have to improve some areas, like our integration with the MSNP intervention. So MSNP, the approach-wise very good, but the understanding level in the higher levels, central level, and the grassroots levels will be quite different. Even in our local government, now we have federal country, so we have the local governments. So still local government have not better understanding about the MSNP program. So this is a very major gaps, I think. And so how to integrate MSNP and others interventions like IMAM, yeah, and same like interest of local government. So local government always not so much understand about the importance of the nutrition value or how to minimize the malnutrition cases in the local levels. So how do we facilitate to our local governments? I know our expert, we have the very good knowledge in ourselves, but how our knowledge to deliver to the grassroots levels, and grassroots are not understand our expert knowledge. These are also big gaps, and that same like ownership and accountability. So very less ownership, accountability regarding the IMAM program and other interventions also in the grassroots level and from the governments. And other gaps, I feel supervision and monitoring. So supervision monitoring not from the top levels, even a supervision monitoring in the Palika level, how to monitoring, how to the track in the real target groups. So and same like in the provincial and federal levels. So supervision monitoring means not only checking, it also give the knowledge how the program is going on track. And same like our data quality. Yeah? Already our expert previous our presenter present very quite very good data. Yeah, but I just according to my experience, how to believe the data. Data is very very political things, I think. So data always, even in my experience, several hospital and several health posts visited in the community levels. Only very few cases there access in the health post. So very data how to their quality and how to verify the data, how the validation of the data recording system. This is also very 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 much gaps in the what our government systems recording in data, and based on those data we have analyzed and then we give the pictures. Yeah, but in the community levels, in the health facility levels, very few number of data entered in the HMS system. So this is also a big gap. Please next. And same like we are talking about the IMOM program. We have, I think, more than 5 districts. Asma had completed the IMOM program with support of the UNICEF. But at that time also, and now even still, we are facing there the RTF is a major supplementary food on the government side, but there is not available in time. Sometimes the big gaps. So this is a big issue in the supply chain system. So this is also one major, and sometimes children have not get in timely to the RTF or super serial, what we say. So this is also one gaps, and storage of the HMS tools, and shortage of the HMS tools, and shortage of anthropometric measurement tools like equipments. I am talking about sometime what the measurement of the under 5 children is very important and very crucial. But our equipments, in terms of our equipment, has the quality or not? It is quality or not? Sometimes maybe height board and mark tape, they're not so quality. Then and at the same time, our health workers, how sincerity they taking the measurement. So we have to think about it. If a measurement is not properly, then maybe the data will come different. So very crucial things is anthropometric measurement tools, and same like reporting and recording. This is next. And same very important screening. I think KP Lamsal also said about it. Screening is very important. In our community levels, case identification, admission is very less. So number of cases, if we scanning, we find out very less number, then very difficult to analyze the larger scale. So scanning is very important, but in our community and mother groups, even still not send their children to the health post or nearby their health center for the scanning. And even our government's program very focused on scanning, because less than 20% children scanning by the local health facility. So this is also a big gap. If we have not scanning properly and not a large number, then how to identify? These are also very much gaps. And a lack of follow-up and in those some cases. Actually, sometimes we find out the SAM cases, but where the we don't, those cases are, and also how to support them, even not proper counseling, treatment protocol. Even if we have some facility in the provincial levels, but mothers are not interested to go there to take the facility, what our facility from the government side. So this is also a gap. How do we counseling to them to admission in time, proper time for treatment? This is also one gaps. So and same like I'm not to blame, but even in health worker in the field levels like FCHB and health workers. So some gaps even in planning and some scanning, different way, and sometimes it's not proper who our target, like marginalized community, Musar community, even in the Dalit community, where that very much necessary to support, but our health workers not reach there, those community, and sometimes those, but very superficial, I think, and not properly. Even I know even some family I'm not literate. Some family there are no any even not only parents, maybe grandfathers, grandmother. I'm not literate, and for those family we cannot support at one time. They take the more time to visit the more time for the counseling. So how we encourage those community and how we make the passion ourselves to support this family. So these are the gaps, I think. But we hopefully we can do this. But I think to think for that point. And same like budget, like question for IMAM intervention from the local side, like local government, I'm not budget allocation for the nutrition program or others intervention in the community levels. They have not give the more priority. Maybe this is a new federal system. Maybe in coming days, they know about the importance and program and increase maybe budget. But now they feeling, my feeling is that some budget location very low for the intervention of the nutrition program. And number of OTC, even very limited number in OTC center in the community level. But OTC, we have some OTC center in the health post, but not proper functioning. So and utilization there OTC. So I think those are the gaps in the grassroots levels. And other thing, we have some more experience on the positive deviance approach. We have also conducted the nutrition-based program. We call the positive deviance approach. The positive deviance approach always focus to identify the local food and local knowledge, local behaviors, and those knowledge we scale up to the other family. So the very fantastic approach, the positive deviance approach. And according to our this positive deviance also research, I think is for the community levels. And positive deviance approach that drive the health personnel and non-health personnel to know about the community knowledge. And even now in a federal system, even we have our approach, the top to bottom approach. Always we have from the top level to the influence to the local levels to do these things. But my perception, my experience now in a federal system, we know about is we more collaboration, more consultation with the local governments, local community. Then we identify the good approaches and good intervention for the community levels. So these are also gaps. I think in the nutrition food now we especially in even a community level we easily find out the junk food. These are so how to minimize these things. And finally, and last point is the insufficient community awareness activity. Still, we know some community awareness, but still to continue these things and like of local level engagement and okay.
Okay. Thank you, sir. Thank you very much for your highlighting and sharing of the experiences of community perspectives of IMAM and the best case practices that were done through the NORP camp of ASMA Nepal. Thank you very much. And with this, we've come to the end of all the presentations from our invited speakers for today. Again, requesting our participants to redirect any questions if you have for Novel Sir in the chat box below. Now, before we move on to the Q&A section for today's webinar, I'd like to request all our speakers to turn on their cameras before we begin. And even though we exceeded our allocated time slot for today, I think I was noticing that there were a lot of back and forth question and answers in the chat box itself, which is a testimonial that today's webinar session has been very much interactive, and we really appreciate the active participation of our participants. Now, our team has collected the questions from our participants today, and I could see that there were some questions directed to Dr. Karine from Navin Paudel sir and Deepak Thapa sir, which she has rightfully replied to. So Dr. Karine, would you like to elaborate something more on those questions?
Yes, thank you. And thank you for your questions. I wish we had more time to exchange. I think the study, like the one we did, is just one of the first steps to really understand what are the barriers. We studied basically the perception and from a social psychology perspective, and see how the mothers perceive themselves, how they perceive their children, the community perceive themselves, and how basically what they cannot express directly, but what for them means to have good healthcare for their children, even though they don't have the means to provide it or to make decision. But this study is really the first step. We need to go, further to really understand and test some intervention or ways of improving the consultation with the mothers and the children, and test those interventions, those ways of giving information, what really works, what doesn't work. And this, I would be, very happy if we could do this kind of study, because I think this is what is missing between the study on social representation and on actually how the healthcare system is implemented.
Yes, thank you, Dr. Karine, for addressing those queries. Now moving on to KP Lamsal, sir. So we had a few questions directed at you, sir, and I'll go through those, and please respond to it one by one. So we had a question for you from Dr. Manoj, who had pointed out the failure of supply of RUTF as the national program, and he has asked about your opinion on a possible alternative for this. And the next question directed for you, I think it was between you and Dr. Subhash, so I'm keeping it out to both of you. Our participant B. Poon has asked about the recommendation on introducing small quantity lipid-based nutrition supplement for the most at-risk children in Nepal, given that the promotion of local foods has been discussed for a long time without any notable improvement. So he or she wants to know your opinion on this. Over to you, KP sir.
Thank you, Nihaji. Actually, for the supply chain break of RUTF, I think we should follow the clinical protocol to treat the severe acute malnutrition children. So there is no any alternative to use local food and other product to treat severe acute malnutrition cases. But we should improve the supply chain mechanism of to time the supply of RUTF or the therapeutic milk as well. But most importantly, the use of local recipe and local food product to prevent the children and to prevent and treat at the stage of moderate acute malnutrition or prevention even before mild or moderate wasting is crucial. So I would like to focus on the prevention part first. But for the treatment, I think as per the global guideline as well as the national protocol, we should use the therapeutic product to treat the severe acute malnutrition. For the second question, the promotion of local recipe, we have been promoting this from the day first of this program. But if we review the implementation part or the adaptation of our promotion, the promoted recipes or the local food product, we can see the effectiveness of our approach. So we should identify the behavioral insight or the barrier or enabler why the mother or family member, they are not feeding their children with the local recipes. So there is no alternative to promote locally available nutrient-dense food for the prevention part. So it should be integrated with the social behavior change approach and the effective behavior insights. But for the treatment part, for the severe acute malnutrition treatment program, the use of therapeutic food is should be there, either a liquid-based product or any other product, but that should be in line with the global protocol as well as the national protocol of the IMAM program. Yeah, over. If you allow me, I couldn't share the recipe book that I was highlighting during my presentation, but I couldn't share due to the technical error. I just want to briefly share the overview of this recipe book. Is it visible now?
Yes, sir.
Yeah, this is the recipe book developed by the government in the leadership of Department of Food Technology and Quality Control. We can find different recipes inside this recipe book, and I just want to highlight one recipe over here, and you can see the all recipe. They have the household measurement, and the household measurement reflected in gram or milliliter as well, so that the mother or the family member, they can easily measure the raw material as well as the cooked food to serve their children. So most of the recipe we are already familiar, and we have been promoting from different program. This is just the compilation of those recipe, and analyzing the recipe from the nutrition lens as well, especially the protein content, carbohydrate, and the calorie content, and how to prepare those food product in their own kitchen, and what are the raw material they need to prepare those type of recipe. And there are 3 recipes for moderate acute malnutrition as well, which the mother or family member, they can prepare in their kitchen, and they can feed their children. So this recipe book contain almost 21 recipe for the regular food, as well as 3 recipe for the moderate wasting or mild wasting cases as well. I think we can we actor and the government as well as the development partner, we can best utilize this type of tools to promote locally available nutrient-dense food, to promote the healthy eating practice as well.
Thank you, sir. Thank you very
Over
much
to you.
for sharing about the recipe book, which was the best example of the localized solution. Now, moving on to our final question that has been directed to Dr. Subhash. There were some questions that Dr. Subhash had already addressed in the chat box, but I see one question by Pratima Kharel, where she's asked about the coordination with private hospitals for the treatment of SAM cases. So, Dr. Subhash, over to you.
Thank you, ma'am. Thank you, Pratima ma'am, for this question. So basically, the SAM cases are increasing. So it is not actually increasing. They are coming into our highlight. They were in the community level also. So right now, ITC centers, when they are being established only in the government settings, so the case burden load is very high for us. So we almost have about 7 to 8 cases per month admitted in ITC. So if this coordination will also, Government of Nepal will formulate a policy to coordinate and establish these ITC centers even at the private hospitals. So definitely the burden of our government hospitals will be decreased, and the cases will be admitted at the private hospitals. So this will be example to a public-private partnership between the government and the hospitals, as well as it's better to start from the medical colleges. So if the ITC centers will be established even in the medical colleges, this will be learning session for the medical students, for the MD students, and even for nursing students. So they will have better care, the SAM patients will have better care, and our work burden will also be less. So there is a government policy that 10% of the beds, even in the private hospitals and even in medical colleges, will be free of cost. So if we can, just ITC is not a big thing. It is just a new term. Cases are being admitted with medical complicated cases are already in the medical colleges themselves. So only we need to give a solid saying that you have an ITC. So this is the protocol, you follow the ITC. So I think most of the medical colleges are willing to establish ITC in them. So we can also enforce private hospitals to establish ITC to provide free services to some patients, because our government policy also says that 10% of the beds should be free. So if we coordinate, obviously the some cases burden to us will be decreased, and the patients will also have quality of services. Thank you.
Thank you, Dr. Subhash. With this, we've come to the end of the Q&A session. I'd like to thank all our speakers once again, because I saw that you were addressing the queries even while we were having the session, and it was quite an interactive conversation with your active participation. Now, I've been notified by our speaker, Naval Kishore sir, that he has to leave for another meeting, and unfortunately, we have exceeded our time slot for today. So I think before we move on to the final closing remarks from our CEO, Ms. Bonita Sharma, we would like to request all our participants to turn on their cameras for a group picture to memorize this wonderful session for today. And I'd like to request our technical back support team to facilitate the group picture. Can you please let us know once you're done in the chat box? Yes, thank you. Thank you so much. Thanking all our speakers once again. And before we move on to our final closing remarks, I would like to thank all our participants who joined in today. We exceeded our allocated time slot for more than 35 minutes, but even though there was a very good interaction amongst our speakers and participants, and also to our invited speakers, thank you very much for giving such an in-depth analysis and holistic presentation of your work and experience on acute malnutrition management, from covering to the global context as well as the local context. I think this has been a great session for both of us in regards to an exchange of this learning that we've had in our individual sectors. And finally, I'd also like to thank our technical back support team for providing all the technical assistance for the session and its deliberation today. Yes, now I'd like to hand over and introduce Ms. Bonita Sharma, the co-founder and CEO of SOCHAI, for the final closing remarks. Thank you, and over to Bonita.
Hello and namaste, everyone. Today, while I was listening throughout the webinar, I feel so encouraged, so motivated, and so much information within these 2 hours. And firstly, I'd like to thank Action Against Hunger, ACF, NTAG, and Eleanor Crook Foundation for making this possible. I know we are a very young team, and this is our first experience hosting a webinar of such a big scale, where we got so overwhelmed by the number of registrants. So we had almost 200 registration, and among them 125 show-ups. I think it's a very motivating thing for us. And second of all, I mean, our brilliant speakers. I got to learn so much about anthropometry at discharge and risk of relapse in children. We got to learn about the intersectional lens for understanding the health-seeking behavior in Nepal. We also got a bit of understanding of local context, especially at the national level as well as local level, local solutions such as the recipe book, SPC approaches. We also discussed on the clinical management of children with SAM, and it was so wonderful to see all the visual representation of how the process goes at the hospital level. We also discussed on potential roles of private sector engagement and medical college engagement, which could be one of the areas that we could explore on as we move forward. And it was also wonderful learning about the community level practices and gaps. So all in all, although it was limited time, I think we learned a lot. And I'm very thankful to our very active participants. We got over time, but we were still getting questions, and speakers also actively responded, so we could also save a little time at the end. So thank you very much, everyone. And we look forward to creating platforms for such conversation in future. This is the first, but this is first of many. And I look forward to working with you all in future. And last but not the least, although the webinar is of 2 hours, we've been preparing for this for almost 2 months. And I know that our partners and speakers and my team members and our technical support team, who might not be a face here, but they are at the back. The BTS scene is very active as well. So thank you very much, everyone. I apologize if I missed out thanking anyone, but I could see diverse representation in the participants as well, including the government sector, UN agencies, NGO, private sector, youth, and civil society organizations. Thank you very much from the entire team of SOCHAI, and we look forward to working with you in the future.
Thank you, Bonita. Thank you so much. Thank you, everyone, once again from the joint organization of ACF, SOCHAI, and NTAG. We thank you for your presence, and we look forward to meeting you again very soon in another learning platform. Thank you, and have a lovely day ahead.